Welcome to the deep dive. I was thinking about this earlier. Imagine having a map so incredibly detailed that it actually makes it harder to know where to drive.
Oh, yeah, like information overload.
Right. You can see every single pebble on the road, every microscopic crack in the pavement, to the point where you paralyze your own navigation. And that is kind of the exact dilemma facing modern oncology right now.
It really is. I mean, we've built these extraordinary biological navigation systems, but the older, broader roads we used to travel by, they don't perfectly align with this new, hyper-detailed terrain.
Yeah.
Our imaging technology has, in many ways, just completely outpaced our historical treatment data.
And nowhere is that more obvious than in how we handle prostate cancer. So today our mission for this deep dive is to decode this massive, newly updated document, the December 2025 ESMO Clinical Practice Guidelines for Localized and Locoregional Prostate Cancer.
It is a dense one, for sure.
Very dense. It's this multi-author medical oncology blueprint. And for a long time, treating this disease was a blunt force, one-size-fits-all approach. But this document proves we have fully entered the era of precision medicine.
Absolutely.
And this matters to you listening right now because prostate cancer is incredibly common. Whether you're navigating a diagnosis for yourself, advocating for a family member, or you're just really curious about the absolute cutting edge of human health, understanding this document is essential. Okay, let's unpack this. It's basically like upgrading from a clunky flip phone to a smart device.
Yeah.
It's all about high-definition targeting now.
That's a great way to put it. It represents a profound shift in clinical philosophy. We are moving away from just indiscriminately seeking and destroying and moving toward deeply personalized, highly calculated interventions.
Exactly. But before anyone can be treated, obviously, we have to find the threat.
Yeah.
But jumping right into this document, the first major hurdle they emphasize isn't just detecting the cancer, it's avoiding finding the wrong kind of cancer.
What's fascinating here is how the medical community is actively trying to prevent overdiagnosis.
Wow, really? Preventing diagnosis?
Yeah, well, overdiagnosis, because overdiagnosis is the central tension in modern urology right now. We are dealing with a disease that, in many of its forms, is completely indolent.
Meaning it's just super slow.
Exactly. It moves so slowly that it might never actually threaten the patient's life. So the medical community is actively pushing back against the instinct to just, find and treat every single cellular abnormality. Treating an indolent disease causes immense, unnecessary physical and psychological harm.
Which brings us to the famous PSA test,
Yeah.
prostate-specific antigen. For years, this blood test has been treated like a smoke alarm for cancer, but, well, it's incredibly blunt.
Very blunt.
The PSA is literally just a protein produced by cells in the prostate gland. Normal cells produce it, and cancer cells produce it. The guidelines know that moderately elevated PSA levels, somewhere between 3 and 10 nanograms per milliliter, they have very limited specificity.
Yeah, because a big, perfectly healthy, aging prostate naturally produces more of this protein anyway. Or a prostate that simply has some benign inflammation.
Right. So that blunt smoke alarm might go off because you have a raging fire, but it also goes off if you just burn a piece of toast.
That is exactly the problem with it. That's why the guidelines emphasize a much smarter metric now, which is PSA density.
PSA density. Okay, how does that work?
So you take the total PSA level in the blood and you divide it by the physical volume of the prostate gland. By calculating the density, we filter out the noise of normal prostate growth.
Oh, that makes total sense.
Right. If the PSA density is greater than, say, 0.15 or 0.2, it signals that the gland is pumping out way more protein than its actual size should allow. And that strongly hints at a malignant tumor.
But the real diagnostic superstar here is the multiparametric MRI. I mean, in the past, if your PSA was high, doctors would just do a biopsy, essentially poking needles into the prostate blindly, hoping to hit the cancer.
Which is pretty terrifying when you think about it.
Totally. Now, the MRI gives us a map before a needle ever touches the patient. And it doesn't just take a picture, right? It looks at how water moves.
Yes, the diffusion of water, it's brilliant.
Cancer cells are greedy and they're densely packed together. Because they're so jammed in there, water molecules can't move around as freely as they do in healthy tissue. The magnetic resonance of the MRI detects that restricted water movement, highlighting the exact locations of those dense tumors.
And then they grade those suspected tumors using the PI or DS scoring system, the prostate imaging reporting and data system, which scales from 1 to 5.
Okay, so 5 is bad.
Yeah, a score of 4 or 5 means the cellular density strongly suggests clinically significant disease. The guidelines dictate that a biopsy is absolutely required at that point, and the doctor can target the needles directly at those specific dense spots.
But if we look at the lower end of that scale, there is a massive win for patients here. If you get a PI or OTA score of 2 or less, and your doctor's overall clinical suspicion is low, the guidelines say you can actually skip the biopsy entirely.
Yes. Sparing a patient from an unnecessary biopsy is a major victory. It prevents severe anxiety, pain, and, potential complications.
Speaking of complications, the guidelines strongly recommend a shift in how those biopsies are physically performed when they're necessary.
Right. The approach is changing.
The historical standard was a transrectal biopsy, where the needle passes through the rectum wall. But the new gold standard is the transperineal approach, passing the needle through the perineum, the skin between the scrotum and the anus instead. Why is changing that entry point such a big deal?
Because the rectum is full of bacteria. When you pass a needle through the bowel wall and into the prostate, you risk dragging that bacteria with it.
Oh, yikes.
Yeah, which historically led to severe infections and sepsis. To prevent that, doctors had to prescribe heavy courses of preventative antibiotics. But the perineum, however, is just skin.
So it's much cleaner.
Exactly. It can be easily sterilized. By going through the perineum, the risk of sepsis drops to near zero. You eliminate the introduction of that specific bowel bacteria, which beautifully aligns with a massive global health initiative antibiotic stewardship.
Which is huge right now.
Right. We can perform this highly invasive procedure without unnecessarily contributing to antibiotic resistance.
Okay, so let me ask you this. If the MRI is the high-tech thermal camera showing us exactly where the fire is, why do the guidelines even bother keeping the old smoke alarm PSA test around at all?
Well, it's a great question. It's because the MRI is expensive and time-consuming. You can't just give an MRI to every single man over 50. The PSA is still a cheap, easy first filter. You just have to know how to interpret it without overreacting.
Got it. Okay, so let's say the MRI lights up, the targeted transperineal biopsy is performed, and it confirms clinically significant cancer. We don't just rush the patient into the operating room. The guidelines break the disease down into strict risk stratification buckets.
Right, they use categories: low, favorable, intermediate, unfavorable, intermediate, high, or very high risk.
And for high-risk patients, we need to know if the cancer has left the prostate gland. This introduces what I think is the most fascinating piece of technology in the whole document, the PSMA PTCT scan.
Oh, the PSMA PT is a total game changer.
How does it actually work?
So PSMA stands for prostate-specific membrane antigen. It's a protein that sits on the surface of prostate cancer cells like a tiny flagpole.
Okay.
For this scan, we inject the patient with a radioactive tracer that is chemically engineered to act like a heat-seeking missile. It courses through the body, finds those specific PSMA flagpoles, binds to them, and emits a signal.
Making even microscopic clusters of cancer cells, whether they are in a lymph node or a bone, literally light up on the screen, is basically like upgrading from a fuzzy 1990s satellite image to Google Street View.
That's the perfect analogy. The resolution is just unbelievable compared to old-school bone scans.
But here is the catch that completely stopped me in my tracks while reading this. The guidelines specifically warn that if a patient has tiny metastatic lesions visible only on this new super-sensitive PSMA PNET scan, but their older conventional scans are totally clear, they should not be denied radical local treatment to the prostate.
Yes.
Wait, if we can literally see the cancer is spread to other places on this new PSMA PET scan, why do the guidelines tell doctors to ignore that and treat the local area anyway? Isn't that totally counterintuitive?
If we connect this to the bigger picture, you've hit on the exact dilemma we mentioned at the start. All of our historical clinical trials, the massive, decades-long studies that prove surgery or radiation cures patients and extends their lives, they were based on patients who had clear conventional scans.
Yeah, because they didn't have PSMA-P technology back then.
Exactly. They just didn't have the tech to see the microscopic spread.
Meaning many of those men from the 1990s and 2000s who were successfully cured by local surgery probably did have microscopic spread. We just couldn't see it.
Precisely. If we now use our hypersensitive PSMA PET scans to reclassify today's patients as metastatic, and we deny them the local surgery or radiation that would have cured them in the past, we might inadvertently be harming them.
Wow.
Yeah, we cannot withhold a historically curative treatment just because our new cameras are almost too good at finding microscopic disease that the body or systemic therapies might have handled anyway.
The map is so detailed, we have to be careful not to talk ourselves out of driving the car.
Right.
So once we have the risk profile on the high-definition map, we have to choose a treatment path. And ironically, for a huge portion of patients, the guidelines recommend doing the exact opposite of attacking
Yeah.
the tumor. They recommend patience.
The strategies of watchful waiting and active surveillance. Watchful waiting is generally for much older patients or those with significant other health issues where we just manage symptoms if they ever arise.
And active surveillance.
Active surveillance is a strict, highly intentional strategy for low risk and some favorable intermediate risk patients. You use repeat PSAs, MRIs, and biopsies to monitor the cancer safely. You only step in to cure it if the cellular biology starts to act aggressively.
It's like watching a slow-moving storm on a weather radar. You know it's out there over the ocean, but you don't immediately board up your windows and evacuate your house if it might just dissipate or never reach the shore.
That's a really good way to visualize it.
And the bedrock evidence supporting this is the PROTECT trial. This is a massive study with a 15-year follow-up comparing active monitoring against actual interventions, radical prostatectomy, which is surgery, and radiation therapy. And the headlines from that trial are fascinating. At 15 years, there was no statistically significant difference in mortality between the three groups.
Run it all.
But if you look closely at the math, the active monitoring group had a metastatic progression rate of 9.4%, compared to roughly 4.7% for surgery and 5.0% for radiation. So let's unpack this. If active monitoring literally doubles the rate of the cancer spreading, 9.4 versus 4.7, how can the study conclude there's no difference in mortality? How does that math make sense to a patient sitting in the doctor's office?
This raises an important question, and it really comes down to the competing risks of life. Prostate cancer, particularly the low-risk type placed on surveillance, is usually incredibly slow.
Right.
Yes, the monitoring group had a higher rate of the cancer spreading eventually, but because the disease takes decades to move and because these men are often in their 60s or 70s, they were unfortunately passing away from other natural causes, heart disease, strokes, old age long before the prostate cancer ever became lethal.
Imagine the sheer psychological fortitude it takes to hear a doctor say, "You have cancer," and then choose to do nothing but watch it.
It requires immense trust in the medical team, but the trade-off is profound. The patients in that trial who had immediate surgery or radiation had less cancer spread, but they suffered significant long-term urinary, gastrointestinal, and sexual side effects.
Oh, I see.
Yeah. Active monitoring spared men from those side effects for years, sometimes for the rest of their natural lives. It forces the patient to balance absolute cancer control against the daily lived reality of their bodily functions.
But for those who do need to act, the unfavorable, intermediate, or high-risk patients, the guidelines show how much radiation technology has evolved. We aren't just doing the grueling 8-week daily radiation marathons anymore. The guidelines now strongly recommend moderate hypofractionation.
Which is fantastic for the patients. Hypofractionation means delivering fewer total treatments but using much larger doses of radiation per session.
Isn't that dangerous for the surrounding tissue?
Not anymore. Advances in targeting technology allow us to safely hit the prostate with a larger dose without frying the surrounding bladder or rectum. It's vastly more convenient for the patient, reducing weeks of daily hospital visits, and the data proves it has equivalent toxicity and success rates compared to the old, drawn-out schedules.
They even mention ultra-hypofractionation, or SBRT stereotactic body radiotherapy. Just a handful of highly targeted massive doses over maybe 5 sessions.
Yeah, 5 sessions and you're done.
The guidelines cite the PACE-EB trial, which showed a 96% biochemical recurrence-free survival rate at 5 years with SBRT, meaning 96 out of 100 men can go a full 5 years without ever seeing that dreaded PSA number tick back up. But what happens when the storm on the radar isn't slow-moving? What if it's a Category 5 hurricane from day one? Or what if it comes back after we thought the skies were clear?
This is where we enter the high-risk and recurrence landscape. For very high-risk disease, locally advanced tumors, or cases where it has already reached the pelvic lymph nodes, we have to deploy a multimodal battle plan.
Multimodal, meaning hitting it from different angles.
Exactly. We attack the local tumor with radiation, but we also have to shut down the cancer's fuel supply across the entire body.
And that fuel is testosterone. Prostate cancer feeds on androgens. The STAMPEDE trial is heavily featured in this section. It proved that for these very high-risk patients, you don't just use standard hormone therapy to lower testosterone, you add 2 full years of a drug called abiraterone.
Right, because standard hormone therapy stops the testes from producing testosterone. But prostate cancer is insidious. It can actually figure out how to generate its own internal supply of androgens or feed off tiny amounts produced by the adrenal glands.
That is genuinely terrifying. It makes its own fuel.
It really does. Abiraterone is a mechanism inhibitor that blocks the production of that fuel everywhere, in the testes, in the adrenal glands, and even within the tumor itself. Starving the cancer so comprehensively alongside radiation significantly improves both metastasis-free survival and overall survival.
It's a systemic chokehold on the disease. But perhaps the most emotionally devastating area of the guidelines is how to manage a patient whose cancer returns after initial treatment. Biochemical recurrence, or BCR.
BCR is incredibly tough on patients.
I can imagine. This is when the PSA levels start to rise again. If you had your prostate surgically removed, your PSA should be basically 0. A recurrence is defined as the PSA ticking up above zero point 0.1.
Right.
If you had radiation, the prostate is still inside you, so it still produces some protein. But eventually, the irradiated tissue scars over, and the PSA hits its absolute lowest point, its nadir. A recurrence is when it climbs by 2 full points above that nadir. I liken this to pulling a nasty weed out of your garden, thinking you got the whole root system, and then weeks later you see a tiny new green leaf sprouting from the dirt.
It is highly anxiety-inducing for patients, but a rising PSA is a biochemical signal, not an immediate death sentence. It simply tells us it's time to deploy the backup plans. And the timing of those backup plans is one of the most heavily debated topics in urology.
The debate between adjuvant versus salvage radiation. The guidelines reference the artistic meta-analysis to settle this. Let's translate that game of chicken. You remove the prostate surgically. The cancer is supposed to be gone. Adjuvant radiation means you blast the empty surgical bed with radiation immediately, just in case a microscopic cell was left behind.
Yes, proactive radiation.
Right. And salvage radiation means you wait, monitor the PSA, and only radiate if the number actually starts to rise. The data shows that immediate adjuvant therapy causes unnecessary harm without a proven benefit. The guidelines say we shouldn't radiate immediately after surgery, but instead wait for the PSA to hit 0.2 before doing salvage radiation. Aren't doctors essentially playing a high-stakes game of chicken with the cancer?
It looks like that from the outside, but it's actually a beautifully calculated strategy of harm reduction.
How so?
Consider the numbers. A significant percentage of men who undergo surgery are completely cured. The cancer is gone. If we routinely radiate the pelvic bed immediately after surgery for everyone with risky pathology, we would be needlessly radiating a huge number of men who are already cured.
Ah, I see. Overtreating again.
Exactly. We would be exposing them to lifelong bladder and bowel toxicity for absolutely no reason. By holding our fire and waiting for the PSA to hit 0.2, we only treat the men whose cancer truly survived. And importantly, a PSA of 0.2 is still early enough that salvage radiation is highly effective at curing the recurrence.
And to make that salvage radiation even more precise, we bring our high-tech tools back into the mix. The Empire 1 study demonstrated that if you use a PSMA PET scan to guide the salvage radiation, it vastly improves outcomes.
Right, you aren't just blindly radiating the old surgical bed anymore.
Right. You use that heat-seeking tracer to find exactly where the new weed is sprouting and aim the radiation directly at it. That approach improved distant failure-free survival to over 75%, compared to just 51% when doctors used old conventional imaging.
And if the recurrence is considered high risk, say the PSA is doubling very rapidly, indicating aggressive biology, we have systemic chemical backups. The EMBARK trial showed that using a combination of drugs, specifically enzalutamide, which directly blocks the androgen receptors on the cancer cells alongside standard hormone therapy, dramatically improved 5-year metastasis-free survival.
But we have layers of defense.
We do, multiple layers.
So what does this all mean for you listening right now? We've covered an immense amount of ground decoding the ESMO 2025 guidelines. We've seen the massive shift from a blunt force approach to a highly personalized, deeply mechanical playbook. We have smarter diagnostic filters with PSA density. We have magnetic resonance imaging looking at the very movement of water molecules to map dense tumors.
And the PSMA PD scans.
Right, using radioactive tracers as heat-seeking missiles. We have the data to confidently do nothing but watch and wait with active surveillance, preserving a man's quality of life. And for the aggressive storms, we understand how to starve the cancer of its hormonal fuel using complex drug combinations like abiraterone and enzalutamide.
The overriding takeaway is that knowledge provides leverage. If you or a loved one are ever faced with a prostate cancer diagnosis, you now understand that you rarely have to rush into a panicked decision.
That's the most important part, I think.
Yeah. To ask your medical team about your PI RED score, to discuss transperineal biopsies to avoid antibiotics, and to weigh the deeply personal trade-offs regarding your bodily autonomy and quality of life.
You have options, and you have time to map the terrain. But I want to leave you with one final lingering thought. Tucked away in the early pages of these guidelines is a brief mention of molecular biology.
Oh, the germline section.
Yes. They talk about inherited genetic mutations, specifically BRCA1 and BRCA2, which predispose men to highly aggressive prostate cancer. Right now, the guidelines note that germline DNA testing isn't routine for everyone yet. But think about where this precision trajectory is heading. What happens in the near future when your genetic profile, mapped at birth, dictates your specific screening protocol at age 40, completely bypassing the standard PSA timeline altogether?
It's a profound thought.
Will we eventually reach a point where we can biochemically treat the genes before the microscopic weed even has a chance to form the garden?
It is the ultimate frontier of precision oncology, moving from early detection to true biological interception.
Something to mull over as we watch this incredible science continue to evolve. Thanks for taking this deep dive with us. See you next time.